Okay, we're gonna call it and begin to get started. It looks like many of you have already logged in. Some of you are logging in as I speak, but for the sake of having enough time to attend to the content that we have today, we're going to get started. My name is Kate Wasserman, and I'm with the School of Social Work and the TA Network, and I'm joined by my colleague Lauren Rabinowitz from the TA Network as well as Georgetown University, and we are incredibly excited to be able to bring to you this month's TA Network Early Childhood Learning Community webinar, which is focused, as you can see on the screen in front of you, on an issue of great importance to the field and something that we're all learning a bit about, supporting those impacted by the opioid crisis, workforce training, and IECMH efforts and supports. We have three different stories and from three different speakers today, so we're going to get right to content, but a little bit of housekeeping. Everyone's lines are muted. We'll invite you throughout the sort of scope of the next hour and a half that we're going to spend together to type any questions or comments or more information that you want to know from the speakers in the public chat, and Lauren and I will sort of be the moderators of that throughout the webinar content, and then we will open it up for general questions, considerations, thoughts at the end after we have enough time attributed to each of the three presenters. And at the close of the webinar, if we go till 4 or a little bit before then, when Tiara closes this down, a survey will pop up that gives us some feedback on the content. And we ask you to please take a minute or two just to sort of fill that out. It really helps inform us in the work. As you guys know, we've been really trying since January when we've had the revamp of this webinar series and learning community series to really be responsive to the scope of work that's happening in early childhood as well as the scope of those of you that attend. So we want to hear from you with respect to questions and additional content or support that's needed. With that, I will hand it over to Lauren, who's going to introduce a little bit about this topic.
Thank you so much, Kate, and welcome everyone, and apologies for the sound of my voice. Thank you to my toddler who has once again infected me. So yes, we are really excited to talk about this topic today. And in light of the fact that this is such a big topic, so thinking about the opioid crisis, and I know I personally always feel a little bit nervous when talking about this because I don't feel like I'm certainly not a subject matter expert, yet it is crossing into our work. So we want to just open up with a poll to get some information from all of you about what your comfort is and how knowledgeable you feel about addressing this this crisis. So if everyone is willing to participate, you could just look at the first poll. It's rate your comfort with supporting families experiencing challenges related to substance misuse, and just quickly rate that on a scale of 1 to 5, 1 being that you really don't feel very comfortable, and 5 being that you do feel comfortable supporting families and children that are experiencing challenges as a result of substance misuse. And we are referring, when we say opioid crisis, substance misuse, this is really all big lumped together. Okay, so looks like we are seeing responses fairly across the board, lots hovering in that middle, somewhat comfortable range, which is, I think, to be expected. Some of my evaluation mentors would have told me not to put in that third choice to make people choose, as we often hover in there, but I think that makes a lot of sense. All right, well, thank you so much for responding. Let's briefly, and sorry if this feels rushed, but we just have such rich content from our presenters that we want to get to that. So for the second poll, curious if everyone can let us know if you feel comfortable about local resources that are in your community for those that are impacted by substance misuse. We put just a couple examples up there: self-help groups, treatment facilities, etc. So no, you don't know many. Either you know a few or you do know many. So this is interesting. I'm glad to see that most feel like they at least know a few. And it would be interesting if we had more time for a discussion. Is it that you don't know of them, or are you in a community where maybe there just aren't that many resources? That's another piece of this as well. So it looks like we're pretty mixed between somewhat and knowing many. So I'd say that is probably a good thing. Okay, thank you so much, Tiara. We can close the poll. Thank you all for participating in that little activity. All right. So I just have I have a slide up here that has numbers. I think most of you have tuned into this webinar because you know that the opioid epidemic, substance misuse, is a big, big issue. So there's just a few numbers up here to kind of reinforce that. Some of these numbers are from 2016 and 2017. And just as a comparison, the National Highway Traffic Safety Administration in 2016 estimated that 102 individuals were killed in a motor vehicle crash every day, versus in 2016 and 2017, we're looking at more like 130 individuals. So that really just underscores the massive impact of this crisis. And these slides are all available for you to download, just so you know. And this slide here, Understanding Addiction, we could easily do a 2-hour talk just on this topic, but I just want to briefly underscore how important it is that we have an understanding for everyone, regardless of your role in an early childhood serving system or service. It is important for everyone to understand about what impacts addiction because it is extraordinarily complex. We need to think about risk factors such as poor social emotional environment, protective factors, which could include a supportive family, biological factors such as a family history of addiction, for example, psychological and psychosocial factors such as depression, anxiety, and of course contextual factors, which are very complex, such as your work and community environment, which can look really positive or negative. So just a quick takeaway from this slide here. Addiction is not a disease with a set pathway. It is very complex, and we must keep that in the front of our minds when we are supporting children and families that are impacted by substance misuse. Okay, so with that, I am very excited to welcome Dr. Ann Gadomski. I'm going to read her bio, and then she is going to give us, she's going to continue this conversation. So Dr. Gadomski is a general pediatrician, program evaluator, and health services researcher with particular expertise in the health needs of rural children, youth, and families. She earned her medical degree at the University of Rochester, completed her pediatric residency at the Strong Memorial Hospital in Rochester, and then earned an MPH degree at the Johns Hopkins University School of Public Health. She currently directs the Bassett Research Institute at Bassett Medical Center in Cooperstown, New York. Dr. Gadomski has worked on several projects related to the integration of children's mental health services in primary care settings. She's currently evaluating a new system of care expansion grant in Otsego County. Regarding the topic discussed today, she has published an evaluation of the Neonatal Abstinence Syndrome program in the Level 1 nursery at the Rural Hospital in upstate New York where she works. And she'll be presenting some of that data about NAS today during the presentation. So Dr. Gadomski, it is all yours. Thanks so much.
Hi, I'm so happy to be able to participate in this. This has been a perplexing problem in my career since the late 80s when I was actually in Baltimore withdrawing babies with phenobarb, if you can imagine that. So I'm so pleased to see the way this area has evolved over time, and I think there's some great improvements and some improvements that are actually happening right now as of last month. So what we're first going to do is take a look at this, a brief snippet from this PBS NewsHour, which I thought was a good way to sort of portray what we deal with when we have to withdraw babies from opioids.
The bill, which now goes to the House of Representatives, comes as the risk of opioid abuse among women has soared, and that includes pregnant women whose babies are also at risk. In tonight's Signature segment, special correspondent Allison Stewart reports on how exposure to opioids affects newborns and how these babies and mothers are getting help.
To the trained ear, the high-pitched cry of this 3-week-old baby girl is a sign that something isn't right. Nurse Heather Mishlick at East Tennessee Children's Hospital is taking
You just kind of walked by a baby and you didn't know what was going on. those would be the things that popped out to you the most. Like, why is that baby crying so loud? Why is that baby shaking? Generally, they like
the answer is the infant is going through withdrawal from prescription opioids that her mother took while pregnant, leading to a condition called Neonatal Abstinence Syndrome, or NAS.
Their temperatures are high, their extremities are really stiff, there may have been feeding problems initially.
The baby's mother, who we'll refer to as Katie, she asked to remain anonymous, says her daughter had all those symptoms when she was first born.
When I first had her, she was really bad. Like, she had tremors real bad, and it was the worst thing I could ever see for an infant, to be withdrawn.
The number of American babies born withdrawing from opioids, either prescription painkillers or heroin, increased fivefold, from 1.2 per thousand births to 2000 and 2012. In Tennessee, NAS babies are so prevalent, this hospital has a special unit to treat them. Katie says she was first prescribed opioids for back pain 4 years ago, and then became addicted. A treatment center put her on methadone, an opioid medication used to wean addicts off the drug. Then she unintentionally became pregnant.
I wished I wouldn't have been on it when I got pregnant. I wished I could go back and change it, but I can't. And I wished I could take her pain away.
Katie was told to continue her methadone treatment because if an addicted mother tries to quit opioids cold turkey, that can jeopardize the pregnancy.
And what was she on support-wise before she...
Vanderbilt University Medical Center neonatologist and NAS researcher Dr. Stephen Patrick says a premature birth can be more harmful to a baby than going through withdrawal.
For women who are medication-assisted treatment, as an example, they're more likely to have an infant with drug withdrawal, but less likely to have a preterm infant. That's a better thing. The trade-offs between preterm birth and neonatal abstinence syndrome, I would rather have an infant with neonatal abstinence syndrome.
That's because premature babies often have long-term medical complications, whereas NAS is a treatable condition.
So I'm going to pick him up.
NAS babies need a lot of skin-to-skin contact to be soothed and are kept in dimly lit rooms to prevent overstimulation. When that isn't enough, which was the case for Katie's daughter, the babies are actually given a low dosage of an opioid like morphine to wean them off the dependence they developed in utero from their mothers.
The purpose of treatment is to give them the right dose of opiate that's going to alleviate their symptoms and make them more comfortable and safe during the withdrawal period.
Diagnosing NAS is challenging. There are a range of symptoms which can take a couple of days after birth to appear.
On that clip, but I just wanted you to have a sense of what a baby who is withdrawing looks like. They're very irritable, hard to console, and difficult to feed, etc. And so it's a hard thing to see and take care of, but I think we're making some good progress in this. So as the video clip alluded to, there's obviously NAS is on the rise as maternal opioid use is on the rise. And what neonatal abstinence syndrome applies to is how newborns experience withdrawal after birth. And it's now being called, some people call it neonatal abstinence syndrome, other people call it neonatal opioid withdrawal syndrome. It's still the same ICD-10 code, which is a P96.1. And the thing about this is that we often don't know what is actually causing that baby to withdraw, because there's often a polypharmacy situation or multiple drugs of abuse being used that each can contribute, but we don't know, that we can't pinpoint the exact effect of one drug versus another. And a big offender in this is cocaine, and would you believe it, nicotine as well. So high levels of nicotine, we'll see a baby withdrawing from that and have for many, many years. It's a little bit simpler if a mother is on buprenorphine or methadone and she's been on consistent levels, etc. It's easier to manage those, although methadone leads to a longer period of neonatal abstinence. But the only thing we really can do for kids or babies that have severe symptoms is to treat them with morphine. In the old days, like back in Baltimore, I treated them with phenobarb, but that is not optimal either because it takes a while to titrate them off. So the current management, and like I said, things are changing as of last month. In the next couple of weeks, we anticipate we will be changing our management as well, is using morphine in ever-decreasing doses and monitor the baby's weight and hopefully get them out of the hospital by 21 days. That's our average stay. Now, we are a level 1 nursery, so we're not a NICU, for example. So many babies who have neonatal abstinence are sent from level 1 nurseries to NICUs to withdraw. We don't do that because we feel it's very important to maintain the family and to manage these babies here in the middle of this rural area as opposed to send them an hour and a half away to our closest NICU is in Albany and see if we can do this. And for the most part, we've been very successful. I want to draw your attention to the social management because that's very important. That's becoming the new wave is trying to manage babies without pharmacology, so without using morphine. In some cases, this works really well if you have a large number of family members who can take time to swaddle and pacify and console the baby. Other times, the mother's not there because she's, still using or incarcerated or just not available. So it's hard to have the manpower in the hospital in this teachable moment, basically, or where the baby and the family are a captive audience while being withdrawn. It's hard to find the people to take care of the infant and also provide the social needs that these babies need. So they do best in a calm, quiet, and darkened environment being held one-to-one. And, in the old days, we used to put them in incubators and swaddle them, et cetera, but now we understand that they're better if they're held and breastfed. So it's actually good that we've moved in that direction. Again, the mean length of stay varies now. Some places it's 14, other places it's 30, but the mean length of stay is 23 in many places. A high hospital charge for this, and Medicaid pays for a lot of is probably the most common payer and is the payer here in our area. We have developed a contract for families to help them get through this period of 21 days. And I know that this is hard to read, but when it comes to the diagnosis, and we've made the diagnosis of neonatal abstinence, we know the substances the mother was using, we sit down with the family and the nursing staff and try to walk them through this process of withdrawal. And as you can see, we try to empower the parent or the mother to respond to her infant while in hospital. We try to bring in extended family and friends to help hold the baby. We encourage them to pursue their recovery and knowing that that's a priority and to make arrangements for the baby or the nursing staff will hold the baby when they can at the nursing station. Then there's the regular, safety precautions about visitors who are under the influence and being barred from coming onto the pediatric unit. And we caution them that we cannot predict. We do not have a crystal ball about when they can go home. But the conditions for going home is the baby's no longer scoring high on the neonatal abstinence syndrome scales that we use as scoring, that they're gaining weight and they're otherwise stable, and that the parent is stable. Now, what's new? Well, Boston University is doing a lot of work in promoting non-pharmacologic care, meaning that it's the baby's job is to eat, sleep, and our job is to console the infant. And if there's a way we can replace use of morphine or reduce the use of morphine, that's a good thing because it reduces the length of the hospital stay. So some of the work that they've come up with has shown that there's a 30 to 60% reduction in pharmacological treatment when the baby is swaddled and held. And there's a 30 to 60% reduction in the length of the hospitalization. So there's a program at Boston Medical Center called CALM, and it's called Cuddling Assists in Lowering Maternal and Infant Stress. And this is part of what we currently do, but as the research progresses, it looks like you can make great headway in reducing the use of morphine and other drugs if you have this system of cuddling and consoling the infant in place in the hospital. So it's at Boston Medical, they have volunteers who come in and will hold and cuddle the baby and feed the baby. So the nurse isn't having to do that because you're probably all aware of the nursing shortages that we're experiencing, and enable the parent to go off to pursue their recovery or meet with DSS or Child Protective, et cetera, and do the other things that they need to do to ensure that they can go home. And so this felt like a very good place to expand our services, or the services that will be offered in Otsego County and the system's care, and to reach out to these families to see if we can help with their recovery starting right in, up to 3 to 5 days after the infant is born. Now, people ask, well, why don't we know what the long-term outcomes are for neonatal abstinence syndrome? It's incredibly complicated to isolate one effect. Science isn't really designed to take all of these factors that are presented on this slide and be able to accurately attribute what part of this child's syndrome is explainable by which of these factors. So as a result, it's hard to do long-term studies and say with certainty what drug caused any observed behavioral outcomes or reduce cognitive function or produce psychomotor disorders. We just don't know, and it'll be very hard to figure that out. So as a result, there's no diagnosis that can be applied to NAS long-term, meaning that we don't have the crystal ball to know that NAS will result in increased anxiety, learning disorders, or anything of that nature, but they are very much at risk. So there's been a lot of attempts to try to explain this and how to get at what will be the long-term outcomes so we can anticipate that. So there was a large multidisciplinary joint workshop that started the ball rolling on studying NAS a little more intensively given the uptick in the opioid epidemic. But there's still extremely limited data on child outcomes for NAS. And many research questions were raised at this NIH workshop to try to address that. So what we did here at our small hospital is try to put that program into place where we mix pharmacologic and non-pharmacologic care and try to help mothers get through this period of the baby's withdrawal. And even with trying to help them, we find that, of those able to be discharged home, the ones that were in NAS treatment, so 68% were able to be discharged home, whereas in the comparison group that does still have some drug exposure because marijuana is used very frequently in this area, But so comparing 68% of the NAS babies to the comparison group, which is 89% got to go home, is pretty significant. So this puts a big burden on our foster care and DSS colleagues. And I think that we need to be a little more proactive about this problem and try to do what we can do in hospitals to set people up for success when they leave. So we made a case of, that we should be including these problems of neonatal abstinence syndrome in our systems of care to try to address some of the problems that may occur. And it may not be the NAS exposure or the NAS in and of itself, but it's the whole social determinant effects that are impacting how these children do long term, even though it's been hard to study. So there's no one diagnosis that'll apply to NAS, but we know that they're at risk. And it's a complex morass to get through, but yet we're very pleased that SAMHSA agreed to allow us to include NAS as a diagnosis that can be served by our systems of care.
Dr. Gadomski, thank you so much for that in-depth look at this complex issue. And I just want to highlight for folks, so for the system of care qualifications, it's been a bit of a heavy lift for some of the early childhood system of care focused grants because you need a diagnosis that meets the criteria of serious emotional disorder to qualify for services. And so this is going to be the first system of care that's able to use NAS to meet that criteria. So we really appreciate your advocacy for this issue to Dr. Blau and for his ability to sort of open up and see the application of a system of care and a wraparound approach to support these kids and families. There was one question that popped up in the public chat for you, Dr. Gadomski, about, it's from Karen Plowman. What do you think of the use of Subutex in addiction to the calming techniques and for the mother during pregnancy as well?
Oh, well, that's part of the exciting thing that's happening. So it looks like if we use buprenorphine, which is the generic name for Subutex, that we may be able to shorten stay for infants withdrawing from NAS. And we do have many mothers who are in this area because we do have medical-assisted treatment by primary care doctors that are pregnant mothers who are receiving buprenorphine. And if that's all they're taking, if that's all the mother is taking to deal with her own withdrawal, it's a little bit easier to withdraw the babies. So okay. We may be switching, but this still has to be worked out, from treating not only the mother with buprenorphine, but also the infant. But I think we need more data on that, so that's not why it isn't happening quite yet.
That's great. All right, so we're going to pivot to our next presenter, Dr. Mariana, who I had the opportunity to get to know when she and I were both 0 to 3 fellows, and she's going to speak a bit about her work within this field. I'm going to give you a very brief version of her deep qualifications for this work, and then we'll move into hearing about what she's doing to lead a team in West Virginia to address this issue as well. So Dr. Muriala completed her training in child and adolescent psychiatry at the University of Michigan in 2009. Since then, she's provided mental health services to children in rural counties in West Virginia for 6 years through community mental health. In 2015, she joined Marshall University, where she supervises medical students and residents in addition to clinical work. She is also a fellow with the 0 to 3 organization, an organization that advocates for infant and early childhood mental health. Dr. Muriala is focusing her efforts on helping to build a system of care for infants and toddlers in the household and supporting adults on both recovery and parenting. So with that, I will hand the mic over to Kalpana.
Thank you, Kate. I hope you all can hear me.
Yes.
Okay, great. Okay. So thank you, Kate and Lauren, for having me over, and I appreciate the opportunity to talk about some of the activities that we are doing in our community here. Folks who are following the opioid epidemic probably know that Huntington has been an epicenter for a while. Unfortunately, our statistics were ahead of the curve as the rest of the country started to catch up. And really saw an early peak in the number of babies born with neonatal abstinence syndrome, both here in Huntington as well as in a lot of southern rural counties in West Virginia. This Healthy Connections is a community collaborative initiative that's come up, basically bringing together a variety of stakeholders in the community who are, facing the problem every day, and all of us know that no one person or organization can adequately address all the aspects related to substance use as well as opioid exposure in children. And as Dr. Gadomski, she has laid the groundwork, and it's something that's over time, and it's a continuum. So the initiative that we call is Healthy Connections. It includes multiple collaborators. The university in our city, Marshall University, various schools from it, Lily's Place, which is a standalone NAS treatment unit in Huntington. Babies who are born with NAS and who do not have any other medical issues are transferred to Lily's Place, which is staffed by our neonatologist, but it doesn't have, the ventilators and the beeping, and so it's a more quieter place, more focusing on the social aspects of treatment of NAS and of reducing costs tremendously by not being in the hospital. Other partners have been our Infant Toddler Mental Health Association. Recovery Point is an organization that trains peer recovery coaches, and this has been a great help because having people who have been through this substance use themselves and who are currently in recovery and pairing them with peers who are struggling helps enhance engagement of the patients and helps sustain recovery. Then our local federally qualified health center, Birth to 3 programs. One of our child development services organization had a daycare that was shut down, and they offered to use repurpose the daycare center to help accommodate children who are post-withdrawal, right? And then the city of Huntington, the police, fire, health department, and we also had a patient participant or a parent participant who helped kind of guide the collaboration. So we started getting together a couple years ago, and the structure was basically having an advisory board and a planning committee. And as we started getting to know more people, and again, a lot of this was just people getting together on their own time. And as we started getting together, one of the organizations in our community, Quality Insights, actually offered donation in the form of a person who could help coordinate all the activities. The vision of our group was to provide children being raised in homes impacted by substance use an opportunity to build healthy brains through healthy early relationships. And looking back at all the systems, the variety of systems that are involved in treating mothers with substance use, babies with neonatal abstinence syndrome, post-birth, all the issues that they have, whether it's legal issues, employment issues, child care issues, foster care, all of these things, how to bring all these different organizations together, so we are not rehashing the same thing, and we are communicating with each other much better so that children don't fall through the cracks. And of course, this is easier said than done, but this was our kind of, the overarching vision or goal. So what I'm going to do is, in the next few slides, is just kind of break up this continuous period into some natural time frames, where there are natural breaks, and just go through some of the resources that were already available and what our vision was for that group of family. So the first piece is, of course, during pregnancy, and these are primarily, pregnant women are primarily working with adult services, adult mental health, OBs, and we also have a program that provides medication-assisted treatment and counseling with Suboxone for pregnant women. And so, in addition, there are home visiting programs. So our vision was to pair the pregnant women with maternal recovery coaches. So basically recovery coaches who themselves have been through pregnancy with addiction or while in recovery, so that they can have that lived experience and work with the patient through that. We felt like pairing a pregnant woman with a male recovery coach may not be the best option in terms of understanding what pregnancy is and how what it feels like to have given birth to a baby who's in withdrawal. The other part of our vision was to have social work navigators, and these were case managers who help connect each family to resources within the community based on, where they're at, what their needs are. And we were able to secure a grant locally to help fund these two positions. And of course, once the baby is here, a different set of systems comes into place. And so that would be, neonatology and ICU, pediatrics, it is CPS, birth to 3, all of these kind of come into play here. So one of the things that we like to do with our moms who are while pregnant is we walk them over to the neonatal treatment unit within the hospital, and also to Lily's Place, which was a standalone treatment center, and show them what it's going to look like. We also have CPS workers come in and attend the weekly counseling group with the pregnant moms and explain to them what they can expect and what's going to happen, so to help reduce the fear and to help provide actual information. Another part of our vision was to have a MOMS program, or maternal opiate support program, which is located within the NICU and includes the therapist, a social worker who evaluates the families, offer group therapy, and connect them to services before the baby leaves the hospital, including the peer recovery coaches. And we are hoping to build more services like activities for the moms and offering legal aid and things like that. The next piece is 6 weeks to about 3 years. By 6 weeks, mom is no longer with OB. We are hoping, with the case management, we are able to get her to her 6-week appointment. But, they do lose some benefits where now they are no longer able to follow, attend groups with the MAT program, which is the medication-assisted treatment program, and at 6 weeks, still being a new mom can be really hard. So again, groups like CPS or pediatrics or foster care may bring these children to our attention. We do have some home visiting programs. Then again, birth to 3 in this age group is often intervening, but it would be helpful to have workforce that's trained in therapeutic interventions like, say, ABC, which is attachment and biobehavioral catch-up, or child-parent psychotherapy, which addresses trauma in young mothers, new mothers, and their help kind of alleviate that impact on the baby. One of the things that we are looking at rolling out soon is therapeutic daycare, which accommodates children who are graduates of Lily's Place, or children who may be prenatally exposed to substances. There's a lot of red tape involved, permission for things like swaddling, or allowing parents who are actively using, allowing them within a child care facility. So a lot of legalities and red tape that needs to be worked out that we are trying to get through, so that we are able to provide daycare to these children up to the age that they turn 2 or 3 years old. And then also being a location for family-focused activities. And then finally, the age from 3 years to kindergarten. They are no longer eligible for birth to 3, but being able to see that there is not a gap that between 3 to 5 years of age when they're ready for kindergarten. Of course, public schools do have special education, but again, that educating schools in what kind of services they need, and helping them be more trauma-informed in dealing with children who may have outbursts or who may just not be able to regulate themselves, and passing on information to kindergarten so that they know what they're dealing with. Our School of Psychology is also working with Board of Education, because teachers are coming to us saying that they are having a really hard time managing children who've had these types of experiences. Individualized treatment like parent-child interaction therapy can be helpful. Again, we do not have anyone trained in there, and so that's part of our vision, is we're hoping that we can get more specialized treatment for parent-infant or parent-child dyads. And a lot of these, again, services don't just stop at a certain age or time, and we are hoping that to be able to fill the gaps, we recently opened a long-term residential care for pregnant and postpartum women with substance use disorders, where they're hoping that they can stay with their babies while they're in recovery, and so they have the opportunity to stay in recovery for a longer period of time. We are also hoping to start a clinic which would assess these children developmentally over time and have one place where they can get all their assessments. So, oftentimes when you tell them, okay, call this number, make an appointment with speech, or call psychology, it often doesn't follow through, but being able to offer them at one place can be helpful. Another thing we found was to be able to offer new moms and new parents NA and AA groups within the daycare setting, where they can bring their children and have someone watch their children so that they can focus and participate in the group, because they can share the stressors, unlike in a mixed group where they may not have similar stressors, and they may feel uncomfortable bringing a 6-week-old or an 8-week-old baby to the group. One of our other initiatives is SBIRD, which is Screening, Behavioral Intervention, and Referral to Treatment, which is a SAMHSA initiative, is something that we are using to help increase awareness and reduce stigma within various circles in the society. And we've had a great response, especially from our church community, who are really struggling with making sense of this crisis and trying to help families address these issues. So this is just a little flow chart, and our goal is basically to be able to take referrals from a variety of different places and channel them and help them kind of connect to the rest of these services that are available in the community. because a lot of times people, don't know what's available and who's doing it and how to get a hold, what the criteria are for intake or those types of things. So what we're hoping to accomplish is a longer time for the mother to relapse, decreased likelihood for abuse or neglect, increased likelihood of maintaining the family unit. Here in West Virginia, we are really struggling with finding foster care and kinship care and a safe place for children. But, we're hoping that if the parents can take care of the baby, that is a good outcome for everyone involved. Improving the mother-baby attachment, because we know that trauma can be intergenerational, and then increase the time to next pregnancy. So hopefully, we've been discussing long-acting contraceptives, hopefully so that the mother or the family can focus on the baby at hand. Of course, funding is always a hurdle, and trying to create sustainable services. The biggest issue is finding qualified workforce and for providing maternal infant interventions and funding their training and supporting them, because this is hard work, and the burnout and the turnover is often it can be significant in areas like CPS workers or home visiting. We are seeing quite a bit of turnover because the work is so hard, and so being able to support the workforce and provide additional training can be is something that we need. And as we talked about, substance use is such a multifaceted psychosocial issue that there is always pressing needs, always issues for each agency. Someone's in the threat of losing their funding, or this program is going to lost some staff and things like that. So we're often kind of just plugging the holes, and also policy changes that are needed to help address these issues. So while we may not really know the specific outcomes of opioid exposure, I do feel we cannot go wrong in supporting our parents, no matter how severe or how complicated their issues are. The only way we can support the children is by supporting the adults. And thank you all for listening, and if you have any questions.
Kalpana, this is Kate. Thank you so much for that really thought out and in-depth illustration of the ways in which families benefit when we really wrap around them, and even some of the sort of funding and programmatic challenges that you guys have come up against, like when moms lose insurance after 6 weeks delivery and things like that. Thank you so much. Do you folks have questions? Please put them in the public chat, and then we'll open it up for a general discussion in a little bit. And I hope, as we're sort of discussing some in-depth applications to address this issue for early childhood systems, going from a system building around a hospital to the work in West Virginia that's really sort of considering the different ports of entry and how to sort of hold and support those families. We now want to take a step even a little bit further up the ladder, so to speak, and take a look at some workforce training and development issues. And to that end, I'm going to introduce Mary Lacasse, who we're fortunate enough to have right here in Maryland. She has, for over 30 years, experience in early childhood in the profit, private, nonprofit, and community-based organizations, all focused around supporting early relationships and young kids. And now at the state level, with a focus on maternal and child health and adult learning. Currently, Ms. Lacasse is the Chief of Family and Home Visiting Services at the Maryland Department of Health, where she provides operational leadership to the Maternal Infant Early Childhood Home Visiting, or MCV project, and guides all of the promotion of material and child health in Maryland. She's also responsible for providing technical expertise to key stakeholders, oversees directly funded evidence-based home visiting organizations, and supervises staff to support multiple home visiting initiatives. She holds a bachelor's degree from Salisbury University and a master's from Johns Hopkins, and she's going to speak a little bit about some of the ways that she has, at the state level, programmatically been working to address this issue. So Mary, the floor is yours.
Thanks, Kate. So what I wanted to talk about a little bit today and address is how this training opportunity actually came to be and the relationships that made it happen, because everything really is about relationships. It was the brainstorming of a lunch date between two state partners from the Maryland Department of Health and the Department of Human Services. And as usually happens, we discussed the challenges our workforce faced. And by the time we finished eating, we created a spark of an idea. And we pulled in our training partner who had already developed a home visiting trainer certificate. And we reached out to our national home visiting evaluators to ensure we looked at the project we had created in our minds from all different sides. So why really develop this training, this substance-exposed newborn training that was birthed from a lunch from two coworkers? We know from listening to the other speakers about some of the challenges, what children face at birth, what happens later in development. And many people know home visiting is one piece of a strong system of care. But the workforce are the people that deliver that care. And we wanted to really be able to address prenatal substance abuse risks. The training brought together staff from 3 different sectors. Originally, as you had stated, we had McV, home visitors, and our Department of Human Resources staff and child welfare. But then the State Department of Education said, hey, infants and toddlers works with families of substance-exposed newborns. An early Head Start home visiting option also does this. So we all kind of pooled together, and we decided that this training would focus on issues faced by caregivers and families of substance-exposed newborns and address that addiction, the recovery, the trauma, the stigma, the need for self-regulation, court involvement, custody. There are so many moving parts, right? And how to engage and communicate with these clients to make effective referrals, connect with other local professionals, and integrate services provided to families. So how do we get to the training? It took a lot to develop a training to make it relevant and appropriate for those meeting the needs of families in the home. So a literature review is something we always do, right? So a literature review is done. We've identified and video recorded interviews with 13 advisors who work with substance-exposed newborns. We conducted separate focus groups with child welfare, home visiting, and infants and toddlers staff. And out of the birthing of all of that came a training of 7 15 to 20-minute online modules and a 1-day in-person training. And I'll address those more a few slides from now. Basically, though, when we did all of that, we looked at the literature review, we did our videos, we talked, we did these focus groups, what we really found out was many folks did not know about where to refer. So when we looked at research finding, let's talk a little bit about some of the national research that drove these training guidelines. So the workforce, the people doing the work don't always recognize the signs, the symptoms, or the challenges associated with substance use. And the referral rate isn't nearly as high as it could be, which can be attributed to a bunch of reasons, including not knowing how to approach the subject, being uncomfortable with it, or not even knowing where to refer because you don't have as many resources where you live. There are barriers to engaging families because the many layers that make up this difficult topic. The workforce needs knowledge and training with social supports, psychoeducation, tangible assistance to meet the needs that are complex and often overwhelming for these highly vulnerable families. Home visitors felt ill-prepared to address substance use, and home visitors wanted more training in substance use and addressing the needs of families that they took care of. So when Maryland conducted our beginnings, our pre-test, we looked at 60 folks, we had 60 people survey, and we got some results. Home visitors were asked if they needed more training in working with mothers who didn't recognize substance use as a problem, and 66% agreed with that. 62% of home visitors said they really need more training in exploring mothers' ambivalence regarding seeking help for substance use. 58% of home visitors said they need more training in basic information about substance use treatment and recovery. 78% of home visitors said they needed more training in caring for infants that demonstrated substance exposure. So these online modules I mentioned earlier, there are 7 of them. And the training is formatted into online and in person. These 7 modules are only 15 to 20 minutes online. The reason being, not everything can be conducted in person. Childcare, home visiting, all of these folks are super busy. They have large caseloads. They're very, very busy for multiple hours during the day. So we tried to create something that would work around their schedule for some of their learning. And what we found was the modules are pretty effective. We talk about substance using mothers. We talk about the effects of prenatal substance use, trauma, addiction, treatment, motivational communication. And all of these modules, and the content's based on the national research, and they're woven into then the day-long presentation. So that in-person training covers a lot of things: addiction, stigma, motivational communication, compassion fatigue, agency collaboration. And what has happened in this in-person training is kind of fascinating. So we did a pilot, and we brought together home visitors, child welfare staff, and infants and toddler staff in this one. And what we found was the face-to-face day really included relationship building. One of the most invaluable findings was that people from varying agencies were making human connections. So we were hearing things like, oh, so you're so-and-so. I've been emailing you, and now I know who you are. The face-to-face connections were definitely one of the key takeaways. In the post-training, after that pilot, we asked some questions, typical Likert scale. Do you agree? Do you strongly disagree? Do you strongly agree, right? We shook it out between a 1 to 6 scale. And overall, people felt about 5.2 that the quality of the training was okay. They liked it. That it would help support their work. That was a 5 out of 6. And learning new information got a 4.8 on that scale. So what's next in Maryland for us? We have 6 training cohorts happening through September now that the pilot is conducted, and we've made some adjustments. We've added the early Head Start participants because wherever we can, we feel that it's very necessary because there's a lot of people that meet families where they are in their home. We have ongoing training in the new federal fiscal year because Maryland McVie put up a little pot of money for the development of the training in the pilot, and then the Department of Human Services put up a pot of money for training through September. And as we all know, in every state across the nation, there's only so much money. So now it's back to Maryland McVie a little bit more, and we'll be conducting some more training to roll it out. And then probably our State Department of Education will kick in some as well because we're also training them. And, you know, Maryland is a small state, but there are a lot of people that want this training. They want to be able to have the tools and have the support. And what we found, hands down, is that the more supported the workforce is, the more confident they are, and the less turnover we have. So it's a win-win for us. So now what I'd like to do, that was short and brief because I wanted to keep your attention, I'm going to turn it back to our webinar host.
Mary, thank you so much. Just keeping an eye on the public chat, and some folks are talking about just impressed by the agenda that you had for the in-person training and the value in that. I think, Tiara, we could probably unmute people's phones if they want to speak to sort of any of the different lenses on the work that's happening. And, you know, many of you that dialed in or selected this webinar is something to dedicate your time to because of your interest in it. So please let us know as well any projects or components that you guys are working on. I think this is an incredibly steep learning curve, but important one for the field of early childhood, and something that's really helping us think collectively about how to understand the adult components as well as the dyadic components as well as the substance use components. So there's much to consider there. So we open the floor for questions. It looks like there's a comment here about CMHC has developed a program for pregnant and parenting women with an emphasis on substance use disorders. It was approved a couple weeks ago. Fresh off the press. That's what's so fascinating, as Lauren and I, even in the month that it took us to plan this webinar, so many new things are coming out. It was approved a couple weeks ago and is still pretty fresh. We're also working on a plan of safe care. That's great. We look forward to hearing more about that work. And one of the things that we want to highlight and have been highlighting, and we're working on a little bit of a reorganization, and then we'll contact you a bit more about it, is the opportunity in the IDEAs, which is the new name for the learning management system, where all of these webinars are housed and where you register through. Please post things. Post questions to your colleagues, or supports that announcements that you just got, or information that you're rolling out. Much of this is happening online. Mary graciously put her email address up here for people to contact her directly as well. Karen has a question about fetal alcohol spectrum disorders in the training, or in general, which is another really important issue.
So do you want me to address that?
Absolutely.
Okay. So although specifically FASD isn't a part of the training, it's obviously touched on because alcohol is a substance. And unfortunately in Maryland, well, probably everywhere, there is an opioid epidemic. There's a challenge with opioids. However, the home visiting certificate itself addresses substance use, including cigarette smoking, including alcohol, and the fetal alcohol spectrum disorder is much more closely addressed in that training.
This is Lauren. So I had posted a question in the chat a few moments ago, asking if folks were having any struggles with workforce, and I think we can think about workforce in two areas. So it is actually having folks available, and then part two is that training piece, and that's where we were getting some exciting information about some new initiatives. So I'm just curious if any of our presenters have anything to share about the those two pieces of the workforce issue. So take your pick. But I know we're always struggling across the early childhood field about finding folks that are that are able to do the work and then getting them trained. Any initiatives or anything else that you all know of apart from what you shared today, or anything you'd want to expand on? I'm curious, Dr. Gadomski, anything that has, or actually for you, really for any of you about, like the rural areas, and just anything that comes to mind?
Yeah, this is Kalpana Miriala. I'm sorry.
No, go right ahead.
No, I was just going to say, it is, I think as people who are trained or geared to work with children, and especially infants and toddlers, substance use in adults is something way far away from anywhere they've been in terms of training or reading or, but that is something they deal with. And so really that cross-training or just recognition and then ability to find local resources. So, who would be the best person to hook these parents up with? What's the best way to approach this issue with parents? I think those are some of the things, some of the skills that, again, anytime, CPS is involved, the most common cause for referral is parental substance use. It's unfortunately with opioid exposure, With the NAS symptoms, we know who these children are, and it just right at birth they get involved with so many systems and systems of care that compared to something like alcohol, exposure, which you might not see the effects of those until later. So that early neonatal and early childhood period is much more complicated with opioid exposure compared to, say, tobacco exposure or alcohol exposure or marijuana exposure, all of which, they still do impact child care situation. And so being able to identify all of those, especially because of the use of, the polydrug use. People hardly use just one substance. And so it is crucial to at least recognize, ask about, and then find a way to make a referral or connect with those services.
Well said. I can't agree with you more. I would say that one of the things that I'm intrigued by is this concept of the biobehavioral catch-up that you mentioned, and I wonder what do we know that informs that notion of biobehavioral catch-up? Are there certain things that we can do to help the NAS baby catch up? Or we're operating in a vacuum of research, and with the polysubstance exposure, it's extremely difficult to try and say, okay, well, this is the approach that a home visitor can use, or it's incredibly difficult to pinpoint one thing, and it's almost like what you're left with is a wraparound of supporting the parent and trying to address the social determinants.
Right. So interventions like attachment and biobehavioral catch-up actually focus on, the one-on-one interactions between the parent and the baby or the parent and the toddler. And they do have some long-term, 3 or 4 year out research that shows that the ability of these children to regulate cortisol systems maintains even after the intervention has, completed. And so there is some, research to go with that. As far as specifically with opioid-exposed babies, I don't think there's research yet. But anything, and again, these babies have this double whammy, right? One is the prenatal exposure, and then the other is the postnatal adverse events. So even if we can minimize the postnatal adverse events by home visiting or any of the other interventions, I think that will still help a lot in normalizing, or at least, pushing the developmental trajectory towards normal.
I can't agree with you more. I just this lack of specificity here. I think anything you could do to help with attachment, et cetera, is very important. And Mary, I wonder if in your training, do you cover any of these kinds of general approaches in biobehavioral catch-up, or how does that work?
The trainers address a lot of, they use motivational interviewing to try and get families, because you're trying to help that mom usually sort of see what's going on and have her come around to making these decisions. And it's a lot of, watching these comments about retention and whatever. It's a lot of skill. And the biobehavioral piece, it's absolutely hands down super important. But many of our home visitors aren't clinicians. Many of our home visitors are they're trained differently. So we're trying to give them tools to be able to address what they see and be able maybe to refer more out to where people can address other things. Now, that said, there are programs that use the ABC. There are programs that use different models to ensure that families are getting those needs met.
And this is Kate. I just want to acknowledge for folks that may not be aware of the specific EBP that is being discussed here. So ABC, or Attachment Biobehavioral Catch-Up, was developed out of Mary Dozer's shop at the Department of Psychiatry at University of Delaware. It was actually initially developed, I don't know the year, but around or designed rather for intervening with parents and kids that were reunifying after parental substance use. Not specific to opiates, it certainly predates that, but it's very well researched. So if anybody's interested in learning a little bit more about that application, that's where you would find it. So Mary Dozier at ABC at University of Delaware. The comment as well about retention makes me think just in terms of some of the trauma-informed care practices around sort of staff, like supporting staff that are doing this work and that are sort of delving into these difficult topics with kids and families and seeing the successes and the families that have missteps. I'm wondering if any programs have information to share about what they're doing to support their teams or to encourage that. Part of it is education, but also maybe some reflective supervision or some practices around supporting self-care for staff.
So this is Mary, and I would like to address the self-care, but before the self-care, I'd like to address ACEs, because I think that there's a lot of secondary trauma with folks as well, and many times what we're finding is our workforce deal with or have dealt with the same traumas that they're trying to help their families go through. So we have a lot of work around that as well. How to, if you were someone whose parent abused drugs, and now you're a home visitor and you're going into a home and you have to be a blank slate and you have to be non-judgmental and you don't want your opinions to be portrayed because you won't probably get back in the door ever again if that happens. And it's a very fine line people have to walk, and that also is addressed in this training. There's always, I think, self-care and the need to make sure people do care for themselves, both physically and mentally. It's probably in every training. I see some of the names that are here as the attendees. That people do this. Early childhood's famous for doing self-care because they're the last people that always take care of themselves, right? And I think it's super important because we're asking a workforce who oftentimes doesn't have multiple degrees in multiple things to do a PhD level dive onto each family that they address.
Yeah, this is Lori. It looks like Steve and I were having a similar thought at the same time. That this is such an issue of of staff and caregivers that there's a lot that happens in their lives as well. So it's not just always the vicarious trauma piece, but what might be happening in someone's life at the moment that they are providing services. Mm-hmm. Other questions? Something that you might be pondering in your home community? You have some phenomenal experts on the line right now that have been really generous with sharing information and lessons that they've learned, and I know would be happy to pass any other nuggets of wisdom along.
Steve, this is Kate. I'm wondering if you would be willing to just give a 1 or 2 minute overview of the ACEs training that you guys are rolling out. To just sort of give, I think it's very germane to the topic as I'm seeing it in your comment. He's typing. Oh, sorry. Okay, he needs to call in. Sorry, I didn't mean to put you on the spot, but I think it's a very related, important initiative. I think as he's doing that, I mean, I think it's interesting to hear some of the specific approaches that people are taking, either ABC or the expert. You know, what are ways that people are supporting staff to get some technical support around this?
Well, and I'm also curious about anyone that is, that has some other treatments in place that maybe were not designed specifically for either the NAS population or a substance use issue, but are making adaptations.
I think, and as Mary mentioned earlier, early childhood workers are pretty good in terms of recognizing the need for self-care, but I think also expanding it to other services that do work with these families but don't always recognize it, right? So whether it's daycare givers or CPS workers, even pediatricians, excuse me, they being able to access things like reflective supervision or those types of support or self-care mechanisms can really help in preventing burnout.
So another thing we're doing in Maryland is the workforce probably is the most important thing that we have to ensure that we can actually meet the needs of our families and caregivers. We're bringing a program called Lemonade for Life to Maryland, and we're going to do a pilot training with some of our home visitors here. And basically, Lemonade for Life, and I love the name of it, and, like when you lemon, make lemonades, right?
Yeah.
It really helps sort of understand why reflecting on, a caregiver, the workforce, their own ACEs, is essential to providing the best support for families working through their own ACEs. And I feel really happy that we're able to bring that in and be able to have people take a different look about why where they've been might help make them who they are, but how to address other people's needs as well.
So this is Steve. Can you hear me?
Mm-hmm. Yeah, thanks, Steve.
Sure. I'm not sure I have the answer that people would like. So I'm one of a number of people that's part of the ACES Master Cadre of Trainers. And what we've seen when we do these presentations is there are a lot of people who are high on the ACEs score themselves, even though they're providing services. And if you looked at some of Robert Onda's stuff, he's one of the two medical doctors who came up with this. It's not unusual for caregivers to have similarly high ACEs scores. Again, I don't have answers because the presentation itself, other than emphasizing relationship building, other than emphasizing things you can do in the classroom, doesn't have clear-cut direction. Although what they do say, and it takes a lot of time, it's not just one training, is get people to think about what they need, whether it's a parent, whether it's a staffer. What do they need in order to process this? What kind of support do they need? Do they need to talk to other people? Do they feel the need for some sort of more formal counseling? I just think it's really interesting. And one of the things that I've been fascinated with, and I think it fits with this conversation here, there's a book called Scarcity. And it's a look at people who've gone through extreme scarcity, like famine and that sort of thing. But the author also talks about scarcity in terms of other human needs, so the need for relationships or the need for, let's say, closeness with a parent. And one of the things I've been fascinated with, I'm looking for an opportunity to pair with someone to do a study of some sort, would be to work with people in terms of whether it's with ACEs or something else, when do they get to the end of, for lack of a better word, their emotional intelligence, where they can't take a perspective in working with the parent or take a perspective in working with another caregiver? And how do we provide supports to that? I agree with Mary. We don't have a lot of people with multiple degrees, but I think the other part of it is sort of the psychic energy they have to continue this work. How can they be objective? How can they be caring? How can they be neutral when their own lives may be in upheaval, or when maybe the caregiving setting has just exhausted the last piece of patience from them for that particular time?
Well, thank you all for this reflective and important conversation. And we want to be respectful of people's time and note that we've lost a couple just due to, I think, it being almost 4 o'clock and the end of the day. But for those of you that hung in, we give you credit and our admiration, and would appreciate continuing this conversation in some form or fashion through the Ideas portal, where we'll have this recording and information about other webinars that are coming up. We do this monthly, same time, same channel, relevant topic. We will be in touch through email and through prompts through the Idea system for those of you guys that are logged in into that. Tiara just posted the link there. Thank you so much. Lauren and I will hang on for a little bit if people have additional sort of questions for the public chat, but as soon as this is closed off, a brief survey will pop up. We ask that you just complete that quickly. Again, that really helps inform our focus and our work, and we're always available to talk offline or in the interim. And you have the email addresses of all 3 presenters today. Anne, Kalpana, and Mary, thank you so much for taking the time to share a bit about your programs, and thank you for the incredibly important work that you're doing.
Thank you, Kate and Lauren.
Thanks so much.
Thank you all.
Thank you.
Bye-bye.